Good afternoon. Governments make difficult decisions every day, especially in healthcare. The costs are staggering and the stakes are literally life and death. There are enormous opportunities to help people through new technologies and medications. Understandably, these must be weighed against the overall burden on the public purse. The report I'm releasing today is about one of those difficult decisions and how it was handled in the worst possible way. Ontario is one of 7 provinces that now fund the drug Avastin for colon cancer patients. Avastin is considered part of the standard first-line chemotherapy for certain colon cancers, and after some years of study, Ontario announced last year that it would start funding it. But what the government's press release didn't say was that the government would only pay for Avastin for so long. You could get 16 treatments, about 8 months worth, and then you'd be out of luck on your own whether the drug was working for you or not. To be clear, Avastin is not a cure. But for patients whose cancer has already metastasized, it stops their tumors from growing and prolongs their lives, at least for a while. It is, without exaggeration, their lifeline. Not all patients make it to 16 cycles of treatment. That's the tragedy of cancer. In fact, only about 14% of those who received funding for Avastin in Ontario in the summer of 2008 were still doing well enough to continue taking it past 16 cycles. These patients faced the hideous irony. Thanks to the drugs that their government was paying for, they were lucky enough to beat the odds and survive past 16 cycles with no cancer growth. Their government rewarded them by saying, "Sorry, we're cutting you off. If you want to keep taking the drug, it's up to you to figure out how to pay for it." My report tells the story of the patients who were shocked when they came up against this cruel cutoff last spring. Some have paid thousands of dollars out of their own pockets to keep up treatment. Some have battled with insurance companies. And some have had to give up on Avastin completely and await their fate. This should have never happened. It's not that the government doesn't have the right to deny funding for drugs if it determines the cost is simply too much. Such decisions are common, and they are understandably necessary. But they must be well informed and reasonable. From an ethical perspective, once a decision is made to fund a new drug, any limit on the duration should be firmly supported by medical evidence, not decided on a wing and a prayer. D'un point de vue éthique, une fois que la décision est prise de financer un médicament, tout choix de limitation de la durée de prise en charge devrait solidement reposer sur des preuves médicales. That did not happen with Avastin. My investigation has disclosed that there was no medical support for the 16-cycle treatment cutoff, none whatsoever. The limit was essentially an artificial cost containment measure in diametric opposition to the generally accepted standard of patient care in Ontario. Mon enquête a montré que l'arrêt du traitement après 16 cycles ne reposait sur aucune base médicale sérieuse. L'adoption de cette limite était essentiellement une mesure de compression des coûts créés de toutes pièces et diamétralement opposée au nombre de soins aux patients généralement admis en Ontario. In this report, I recommend that the funding cap be lifted and funding be extended on a case-by-case basis for patients who continue to do well on Avastin. I also called for compensation for those who continue to do well on Avastin, and for those who've had to pay for their own treatments because of the arbitrary cutoff. The ministry did not agree to those recommendations. Instead, it agreed to work with Cancer Care Ontario to develop a new compassionate review policy for cancer drugs, and it invited the current patients to apply for extensions under the present compassionate review policy. Many of these patients and their families are terrified and desperate. Their situation is urgent. Many found it bitterly ironic that the ministry was so quick to justify cutting off Avastin funding, while at the same time, its intemperate spending in connection with eHealth Ontario has been exposed and come under fire. Instead of a workable solution, supported by sound medical practice, the ministry's retention of the Avastin treatment cap continues to perpetuate Avastin justice.
What do you make of the ministry's response in terms of working with Cancer Care Ontario for the compassionate review policy?
There is one big problem with their compassionate review policy. It is that it is not compassionate. What's proposed essentially is a not so clever catch-22 solution where cancer victims continue to be a victim no matter what they do. If you're in the 14%, for example, of those who've successfully responded to Avastin and you're cut off at the 16th cycle, you must demonstrate under the proposed new policy that you've tried a first line of chemotherapy treatment and it has failed. Well, Avastin is a first line treatment. So if it's working, you go to the compassionate policy that tells you, well, you have to prove that the first line doesn't work, and Avastin is working. So you're continually turning in circles. This policy right now, as it's proposed, is as dumb as a bag of hammers. And has nothing to do with compassion. It's contrived compassion, not genuine compassion. So we can't accept it as a solution. It just doesn't work.
En français, M. Marais, pourquoi vous dites que ce n'est pas de la compassion, ce que le ministère propose?
Ce que le ministère propose, c'est que si le traitement de première instance ne fonctionne pas, qu'on peut faire une demande sur cette nouvelle politique. Le problème avec la nouvelle politique, c'est qu'on doit démontrer que le traitement de première instance ne fonctionne pas. Or, ces gens-là prennent Avastin et ça fonctionne. Et donc, ce n'est pas une solution au problème que font face ces patients.